Good afternoon, everyone. So if you had a goiter, it's very gonna be very cumbersome if if you remove it, because you're gonna need a ton of thyroid replacement, up to 1,000 microgram of levothyroxines to replace that. So you better not remove it, but try to administer supraphysiologic doses of T3 every other day, and that has actually worked in one of this on the case series that they studied that. So they've been giving the T3 doses, kind of very high dose every other day, and also checking and that would help with the TSH suppression. So they were giving 150 every other day for almost a year, uh, kind of a decrease here. This is the neck circumference and the weight, also the thyroid. So kind of, sorry, the weight of the patient. And this is kind of, you would see over the year, it went a little bit, but then when they increased the dose, it went even more when they went to 200. And when they went to 250, it actually worked. And the neck circumference went down by 6 centimeters, which is pretty impressive. And the TSH concentration, actually, and that's why we are using the T3, so you don't have like a continuous suppression of it, but more of a graded suppression. If you have a neurological manifestation, and most commonly was described the ADHD, so very controversial. You should usually use the conventional drugs still. There were studies that used a T3 that was found, helpful in reducing the impulsivity. There are other studies who also used T4. However, you need always to check on the other side effects of hyperthyroidism or thyroid toxicity in such patients, which can be a little bit difficult to fully observe. I mean, you would have other symptoms that you want to compare with. Tachycardias. So what should you do in those patients with tachycardias? Typically, we used to use propranolol in our patients or any beta blockers. In these patients specifically, you tend to use atenolol because you don't want to have the blockade of the conversion of T4 to T3, because that's part of the compensatory mechanisms in these patients where the deiodinase is more expressed in these patients. So they would have more conversion of T4 to T3, and they would have more trying to bring on more action of the thyroid hormone. So if you give the propranolol and in a higher doses, and then you block that one, then these patients actually may end up getting worse rather than better. Thyroid hormone analogs. So these are thyroid hormones that they change some of the side chains of it and make it more having much more affinity and less potent. So the most common one is the triac, and this one has 1,000 potency of 1,000 affinity to the thyroid hormone receptor. So they would bind it even much more and have a relatively low hormonal potency. So this has been done in France. The other two has also been done in France and in Europe mainly. It's not available in the US. The fourth one is the D-thyroxine, not levothyroxine, um, um, which is also has been used in some of these patients with a very controversial outcome and side effect profile. And even the study that has used these is like very low numbers, like 3 to 4 patients that had mixed outcomes. Other drugs, corticosteroids, dopamine, somatostatin analogs, and these drugs we all know that they reduce the TSH. The side effect profile of these medication in such patients were not as great, so they are not a standard medication that we typically use. Other experimental studies, so thyromimetics, higher affinity binding and selectively to complement and induce conformational change in the mutant receptor. So this is a very interesting drug called roxadustat, and it's being used in patients with kidney disease who have anemia. And then they found out that it also binds to the thyroid hormone beta with a higher affinity and selectivity to induce the conformational change in these receptors, overcoming the mutation that has been studied. And you could see here, this is when it's being done in the wild receptors versus the when you give the Ridostat to these patients. So this is very experimental. Again, and it's not approved yet, it's still on trials. This is the article I referred earlier on trying to using thyromimetics or thyroid hormone receptor agonist for non-alcoholic fatty liver disease. And this article just came in actually last week in JCM. Using different medications to bind these receptors. Again, all of these are still under trial medications. So back to our patients. Another Tuesday morning, the patient sent me a message and saying that after all the testing and the resistant to thyroid hormone diagnosis and fertility treatment, we found out that she's pregnant. Well, congratulations, 4 weeks. And she mentioned that there is still a lot that we could go wrong, but we are hoping to do all our best in our hand to give us best chance. So what should we do? Schedule an appointment to go over this. Well, before we schedule the appointment, then I had to review all of this. What should we do in pregnancy? So remember that we went through the thyroid hormone physiology, and then if you are pregnant, then that's adds another axis, not only the pituitary thyroid axis, but also you have a placental or fetoplacental axis that you need to take care of. And in the goal in pregnancy, you want to keep a physiological euthyroid status for the mother, for the fetus, and for favorable for pregnancy outcome. Again, you would want to rule out any kind of other autoimmune disease, which was found actually to be associated with 25% of those with thyroid hormone resistance. And then you would guide your evaluation by mutation of the thyroid hormone receptor in the mother and in the fetus. So in that case, you would have 3 scenarios that I'm going to go through. So either you have an affected mother and baby both, or unaffected mother and affected baby, unaffected mother and unaffected baby. All right, so, and then by the way, fertility is not affected at least from the study that we have, fertility is not affected in these patients. This is the major article that endocrinologist has been referred to in thyroid hormone resistance management during pregnancy. Not only that, but also for the effect of thyroid hormone excess on the fetus, independent of the mothers. Because previously they were trying to study if the fetus has been exposed to thyroid hormone excess with a mother who had either like a Graves' disease, but again that was confounded because they have also antibodies, or any kind of like a hyperthyroidism or so on. So this was actually also a chance to study what would happen if only the fetus was exposed to the thyroid hormone excess. So they studied 167 individuals from an Azorian family, and this is a group of family that in one of the islands in the middle of the Atlantic, more of a Portuguese ancestry and also Northern Africanist ancestry. So they studied 44 affected and 123 were unaffected with the thyroid hormone receptor mutation. And that's the mutation that was found in that family, which is actually one of the commonest mutations in thyroid hormone receptors. So this is just a just to see here, these patients have a relatively high free T3 and free T4, and also unsuppressed TSH, and obviously elevated thyroid globulin, indicating a lot of thyroid hormone production. When they check the rate of miscarriages in these patients, so remember, this is an observational study. So here, these are affected mothers. So you would see here the affected mothers who had the receptor mutation had a way higher rate of miscarriages, and that's compared here, miscarriage per pregnancy, and that's compared either to those who or couples who had an affected father, or unaffected other relatives, or even the general population in that island. So pretty high miscarriage rate. And also they checked, how much of, or how many of these newborns that were liveborns had the mutation, and they found the ones that they had the mutations what were born 70, almost 80% to those with mothers who had the affected receptor mutation. So and then those who had their father affected, they had like a 50-50, and you would expect from the way that this is inherited, a 50-50, which is you see here in the father, but that would indicate mainly that those mothers who had a, a mutation gave birth, mostly live birth, to those who had also the mutation. And I'll come to these even more. These are the fetal outcomes. So you would notice here again, these are the affected infants of the affected mothers. And these are the unaffected infants. So you notice those who are unaffected infants that do not have mutation, but their mothers had the mutation. Those are the ones who had a low birth weight compared to their peers in the other groups. Also, same group, infants who had the mutation, who did not have the mutation, but they were born to mothers who had the mutation, also had a low TSH, suppressed during their birth. So again, let's just put it more plain. Affected mothers carrying affected baby. No increased risk either for the mother or for the baby. Pregnancy outcomes is okay, and no increased frequency of unfavorable pregnancy outcomes like premature labor or preeclampsia or so on. And the reason is that would compensate if the baby had like the mutation and the mother had the mutation. Well, it's going to be excess thyroid hormone to overcome that mutation, both in mother and the baby. If you had an unaffected mother and affected baby, so the mother is okay, she doesn't have it, but the baby, they may show some deprivation of the hormone, and in one study that showed like a short stature. The pregnancy outcome was not affected that much. Only one study or one case series showed elevated serum TSH at birth that has been observed. So surveillance for these patients, no basis for treatment unless the baby had a fetal goiter or a distress, and in that case you would give levothyroxine or T3 that was trialed in one of the studies that was given intramniotic. Alternatively, there is another study that also did the trial, which seems appropriate in such patients. Okay, this is the most important part. If the mother had the mutation and the baby did not have the mutation, so obviously the mother has a lot of T4, and that would lead to suppression, TSH suppression, leading to IUGR and fetal hypothyroidism that we have seen in these studies, increase the risk of miscarriage that we showed. So surveillance for these patients, the free T4 should be maintained not higher than 20 and there are other studies who mention 50% of the normal upper limit, and this can be achieved by using PTU or methimazole later in pregnancy. So these are patients who really need the most, closer follow-up. Now, this study in patients who had actually the mutation, the infant had the mutation, and infants who did not have the mutation and the mother were affected. So you would, the mother was not affected. So you would see here these are, the baby was not affected, but the mother was affected. So you would see here they would have a high free T4 in these patients, and this is when they use the PTU and methimazole in these patients. This score was actually not too bad, and also almost no difference in those who had the resistance, same in the mother and the fetus group. Okay, so this is just a summary of what we mentioned so far. If you have thyroid hormone resistance, make sure that you rule out SA interference, TSH, pituitary secreting adenoma. Do not use ablative therapy in these patients. You may need to use TSH replacement in a very high doses in these patients if you end up ablating the thyroid or did a thyroidectomy. These patients, if they had excess symptoms, beta block, like a tachycardias, use beta blockade, and we use atenolol, not propranolol. If they had a large goiter, you try giving T3. If they had a bone fogginess, you may want to try to reduce the T4 or even maintain euthyroidism in these patients by reducing the TSH. If they have some deprivation symptoms, it's no harm that they've been trying this levothyroxine in some of the patients, but again, this is not very well studied, but you will see it in the literature here and there. Most importantly, measure the growth and cognitive development in young adults and also infants. Pregnancy, the most important group that you need to watch out is those with the unaffected fetus of mutated mothers. So you need to make sure these patients are closely followed up. You may consider using antithyroid medication in these patients and to keep the upper normal limit of the free T4 less than 50% of the upper normal limit. Back to our patient. We refer this patient, so we talked to the patient, we went through different, what would happen. The most challenging part for this patient, well, we did not find a mutation in her. So she might be one of those 15%. Again, we don't know which mutation. University of Chicago, and they were also very prominent in this, they have their own lab who also have extra mutations that they check for. So we send a referral to that. You may also want to just test the father, because that would be higher chance that the baby has it. We send a referral for fetal medicine and genetics in case that they want to do like an intraamniotic or villus chorionic sampling to check for the genes for the mutation in the baby. Challenging patient, I think I'm gonna stop here and start with questions if you guys have any. Hope you guys learned something, and thanks for the opportunity.
Thank you, Dr. Muhammad. That was a very nice presentation. And I'm going to open the floor for questions. You either unmute yourself and ask the question or type it in chat box so I can read it for you.
Hi, this is Ty. Nice talk. These are obviously extremely challenging patients, especially when they get pregnant. I find it fascinating about every other day T3 because of its short half-life and how that actually maintains the TSH suppression. Do you have any insights into how we actually maintain that normalization of the TSH with giving T3 so infrequently? Is it just because of the high doses and it has some prolonged suppression?
You mean, so if I answer your question again, that's mainly for those patients who have a goiter?
Goiter, yeah.
Yeah. So it's relatively. So your question is, if we are giving
Well,
that
I guess
amount,
about also the neck circumference and bringing the TSH down, because we're giving these intermittent doses.
yeah. So the question would be, giving such intermittent doses, how we are able to maintain TSH concentration suppression and having the effect of the T3 as well in the long term. So again, I believe, I mean, I don't have a very good answer to that. This what they tried for these patients, but that would be typically you would see, like these kind of receptors try to accommodate, and the cofactors trying to accommodate these high T3. And remember, it's not only you would have mechanisms at the receptor. You also need other mechanisms like the cofactor and so on. And these are, either overregulated or underregulated based on the response of the end organ to the T3. So it's not directly that giving the T3 to the receptor that's gonna sustain that direct effect all the time. But I think it's some involvement of the cofactors and the genes and that is regulating that dynamic of the T3 binding to the receptor as well.
Great, thank you.
This is Joe. I don't know. I put my hand up. Can you guys hear me?
Yep, we can hear you and see your hand.
Oh, okay. Thanks. That was a great talk. I enjoyed it. A very interesting topic. One thing I didn't quite understand: did your patient have a mutation or not?
What mutation?
Did your patient have the?
No. So my patient did not have a mutation.
So that's my follow-up question. What percent don't have a yet identified mutation of patients with clinical thyroid hormone resistance?
15%.
1.5.
1.5.
And maybe they have a mutation downstream.
So either they have a mutation downstream or they would have a mutation in the cofactors.
Yes.
We were not able to detect.
So they don't look at the RXR when they do that.
So they only look at the mutation here, and I mean, again, if here, yes. So here the DNA binding, the T3 binding, these are where they're looking for the mutations, and these are where are like suspecting all the mutations. So they don't look if the cofactors were able to bind here, or the co-regulators, or the RXR. So you might have something going here, and you are not detecting or checking that.
But if you had a mutation in the you would expect also vitamin D resistance, because that's also a cofactor in vitamin D. But could you have a mutation in a promotion or regulatory region of the gene?
Yes, absolutely. And then I mean it's involved in different signaling pathways. So you would probably definitely see something else going on the other signaling pathway that we were not able to detect, or we haven't checked here.
Thank you. I enjoyed that.
So I have one question. So so this particular person doesn't have the known mutation, but let's say she had an identified mutation. So what's the, how do you get the fetal gene? Is that, do you do it in first trimester by cell-free DNA or something like that? Or do you wait till amniocentesis time, or when do you actually try to identify identify the mutation, whether the baby has the mutation or not? What's the timeline for that?
Timeline, you want to do it, you want to do it ASAP. So either chorionic villus sampling in the first 4 to 8 weeks, or after that you would do amniotic sampling. Because you want to remember the fetus would get the thyroid hormone from the mother mainly in their very first trimester or first 10 weeks. So you want to also, check that before the excess happens, because again, all the if you had like a IUDR, fetal hypothyroidism, and goiter, these are shows up early on. There is another interesting mechanism that also being proposed, that the placenta is somehow kind of protective, because again they upregulate or downregulate the deiodinase, which is deiodinase 3 that's most prominent in the placenta. So the fetus might not even end up having that much exposure because of that upregulation. But again, I mean, that's something that you need to be carefully watching.
Thank you. Thank you for the nice presentation, and also all the audience who joined us today. Dr. Muhammad, we'll be in touch.
Well, thank you everyone for the opportunity. If you guys learned something, it's a very interesting field that we keep an eye on. Thank you so much.